In this video, we're going to be looking at identifying a consolidation pattern with lung ultrasound and differentiating between the two main causes, atelectasis and infection. I'm Dr. Alex Estelle, and this is SonoCare. Unlike with much of lung ultrasound where we aren't able to see the lung because of the presence of air, consolidations are areas where we are able to visualize the tissue because the lung is completely deaerated. Consolidations are also called hepatized lung, or originally a tissue-like sign, given that they have a very similar appearance to that of solid organs like the liver and spleen. Critically, we need to be sure that the consolidation is above the diaphragm, as we can be tricked into thinking that what we're looking at is a consolidation, whereas in fact, it's a solid organ. An elevated hemidiaphragm can position a solid organ right where we'd usually expect a lung to be. Here's a scan I did in my early days, calling this tissue density a consolidated lung surrounded by pleural fluid. My mentor helpfully drew my attention to the fact that in the next image we have a kidney, so that pleural fluid is in fact ascites, and that lung is in fact a liver. Consolidations are usually caused by atelectasis or an infectious process. Once you've identified a consolidation, you're going to want to figure out what's causing it. Atelectasis is a bit of a mouthful. It's just the medical term for lung collapse. Lungs collapse when there is insufficient air to keep them open. This means we may get collapse from mucus or secretions that obstruct airways, from the weight of the body when lying flat, or from the inability to take a deep breath in, for whatever reason, often pain or weakness. Whatever the cause, the end result is an area of lung that becomes deflated, and without air, we are able to see the lung tissue with ultrasound. There's no definitive way to differentiate atelectasis from an infectious consolidation, so putting our findings into context is critical. Atelectasis usually exists at the lung bases, so an upper lobe consolidation is usually associated with an infection. Similarly, a unilateral consolidation is usually associated with infection, whereas bilateral symmetrical consolidations are the usual finding for atelectasis. That said, mucus plugging and diaphragmatic weakness can cause a unilateral consolidation, and you can get bilateral consolidations with an infectious pneumonia. So these are really only general principles. It's also important to examine the consolidation for dynamic or static air bronchograms, as well as examine the appearance of the consolidation to look for areas of collapse or recruitability. We're often able to see patent airways within a consolidation. They show up as bright linear structures and may cast a reverberation artifact behind as the ultrasound waves interact with the air-filled bronchus. These air bronchograms, when present throughout the respiratory cycle, are deemed static and are more commonly associated with atelectasis. The air bronchograms may move with the lung as the patient breathes, but are not termed dynamic. That's just the movement of the bronchus as the whole lung moves. They are termed dynamic when we can see the presence of mucus moving within the airway. The literature definition requires 1 millimeter of movement to be termed dynamic, so for practical purposes, if you can see shiny mucus moving within an airway as the patient breathes, you have dynamic air bronchograms. Dynamic air bronchograms are associated far more with an infectious process and are usually a good indicator that pneumonia is the cause of our consolidation. The appearance of the consolidation throughout the respiratory cycle can be helpful in determining the cause. Recruitability is the ability of the lung to temporarily open up during inhalation. We see recruitability when the consolidation disappears as the patient inhales and then reappears as the patient exhales and the atelectasis recurs. This does not occur when a lung is consolidated with infectious material. Infectious consolidations tend to have a much sharper delineation between affected and unaffected lung. When an infectious consolidation comprises only part of a lobe, we can get what's called a shred sign, which is named for the bite-like appearance as we see in the lung tissue. What we're seeing in this clip is an area of consolidation filled with pus beside an area of unaffected aerated lung. If there's pleural fluid around the consolidation, we can use the effect of the pleural fluid pressure to help determine the cause. The way I think about it is that atelectatic lung is a soft tissue mass that is easily depressed by the pleural fluid, whereas an infectious consolidation is filled with non-compressible pus and resists the compression by external fluid. If we see a floppy, concave consolidation, sometimes called a jellyfish sign, we're seeing a lung that's being compressed by the fluid around it and suggests atelectasis. A lung that holds its shape against the fluid around it is a picture much more in keeping with pneumonia and a parademotic effusion. So to summarize, location, symmetry, air bronchograms, recruitability, and fluid pressure are the main considerations when assessing a consolidation. There's a few different factors to consider, but they're usually very helpful in differentiating infection from atelectasis. I hope you found this video helpful. Now get out there and scan.